اتفضلي ولا يا استاذ الدكتور؟ شكرا دكتور أسامة على الدعوة الكريمة للمشاركة في مؤتمرك الجميل اللي ابتدى ناجح وقوي وما شاء الله مكمل. احنا النهارده ل 14 ومكملين والحمد لله على نفس المستوى واحسن كمان. بالتوفيق يا دكتور أسامة، ويسعدني ان احنا نبتدي السيشن الخامس ويكون معانا الاستاذ الدكتور أسامه النجار والمحاضرة بعنوان انيكو انسيرجن بريسكتيف. اتفضل يا دكتور.
شكرا جزيلا لجميع الحضور، ويعني اي ابريشيت ان انتوا حضراتكم يعني هتقعدوا الوقت ده كله عشان تشاركوني بعض من الافكار اللي هي ممكن بتدور في اذهان الجراحين when they are faced with a very dreadful pathology which is necrotizing enterocolitis. Of course, I would like to thank Professor Dr. Osama Hussein for his generous and honorable invitations to share with you. And in fact, I stayed the whole day almost, and I listened to a lot of talks, and I can confess that I start to think why I didn't become a pediatrician and went to be a pediatric surgeon, but of course it is too late, at least for me. In fact, if we are talking about necrotizing enterocolitis, you know better than me that it's a very dreadful pathology, and it's very difficult pathology that we are facing in a very special type of patients who are the premature babies and the babies with low birth weights that are presented in the neonatal intensive cares. If we try to talk about the pathogenesis, I will just take very few words, or I will tell you some very few words about the multifactorial causes of the occurrence of the necrotizing enterocolitis. There are three main groups of factors that contribute to this pathology. The first is the pro-inflammatory condition that is related to abnormal signaling of some receptors, very famous receptor known as the toll-like receptor 4. Number two is the dysbiotic microbiome, and number three is ischemia and perfusion and reperfusion injuries that these babies are at risk for because of a different pathologies that they may have. In fact, the problem in the research and understanding of necrotizing enterocolitis is the fact that there is no clear definition of the case of necrotizing enterocolitis. If we have a sick baby in the NICU, a premature baby with abdominal distensions, with refusal to feed, with some blood in the stool, and with lethargy, and then we come to the differential diagnosis, we'll find that we have a myriad of causes that can lead to these situations. One of these is the necrotizing enterocolitis. So one of the hindering factors and challenges in the research in necrotizing enterocolitis is the lack of case definition. And a lot of researches in the last 50 years have been concentrated upon how to define necrotizing enterocolitis. First of all, I would like just to ask you a question. Do you consider the focal intestinal perforation is the same like or the part of the spectrum of necrotizing enterocolitis, or it is a separate entities? Because sometimes a contamination of the research of necrotizing enterocolitis occurs by including cases of focal intestinal perforations. And in fact, both are two different entities, and their prognosis, their pathogenesis, and their outcome is so much different. So first of all, we have to differentiate between the necrotizing enterocolitis with perforation, with pneumoperitoneum, and the focal intestinal perforations that can occur in a very sick baby like that of the necrotizing enterocolitis. In fact, the problem of in necrotizing enterocolitis, as you know, it starts as a medical disease. Some of these patients will respond to medical treatment. You know better than me about how to treat or how to give medical treatment for these cases. But some of these cases progress. And the problem of necrotizing enterocolitis is that it occurs in an acute onset, and it have a rapid progression. Rapid progressions in the conditions leads to the end points. Even we lose the babies because of the multi-organ failures, or at least if the baby had survived, he will have a very long-term complications like short bowel syndrome, like neurodevelopmental and cognitive disorders. That's, well, at the end of the day, from my point of view, does not represent a good outcome or a successful outcome. So one of the problems for the pediatric surgeons is to assess the severity of the necrotizing enterocolitis and to determine the point at which surgery should happen, or we should interfere at what time to be beneficial for these patients. Actually, in the literature, there is a question about does surgery or doing surgery for cases of necrotizing enterocolitis actually improve the outcome of these babies or not? To answer these questions, we can stay a very long time discussing about the pros and cons of surgery. And the important thing actually is to apply or to do surgery. It does not mean that you are doing a procedure and that's all. You are giving anesthesia to these patients. The patient is subjected to hypothermia, subjected to physiological stresses. All these things can aggravate the initial pathology. And so the value of the surgery here will be diluted in the context of all these factors. I'm sure that you know, all of you know about the Bell's classifications and its modifications. And I would like you to concentrate on these classifications. We have stage 1 and stage 2. And you see that the problem here is the main problem of necrotizing enterocolitis definition. Here we have a suspected NEC. We are not sure that these patients are necrotizing enterocolitis, even in the Bell's classification. That's most of us are using to assess the severity and have a time points that at which we can say that interference with surgery will be of value for these patients. As you see that the classic and the main indications for doing surgery for cases of necrotizing enterocolitis is the occurrence of perforation, is the occurrence of pneumoperitoneum. And this represents what is called the Bell's stage 3A. But we have to understand that about 40% of cases with necrotizing enterocolitis will have necrosis of their intestines without perforation. So it is not only the presence of pneumoperitoneum that can or should determine the need for surgery for these patients. We have to search for other ways to evaluate these patients and to assess these patients to help us to interfere in the proper time surgically to treat these patients. Why? Because as I hear all over the day about the brain-gut interactions and how does the gut can affect the brain developments and the brain functions. And actually, it's very important principle in surgery for these cases is we have to cut the vicious circle of the presence of necrotic gut that's release toxins, and these toxins are going to affect the whole body systems and as well as the brain. It's not only the brain, but the whole body system will be affected. And at the end of the day, we may face with multiple organ failure syndromes and the patients, and we will lose the patients. So actually, the role of the surgeon is to identify the presence of intestinal necrosis. It's not just the presence of pneumoperitoneum that will determine the need for surgery, although this is considered as an absolute indication for doing surgery. The problem is not in this type of patients. And actually, the patients who presented with pneumoperitoneum and who have an early type of surgery, the results in this type of patient or group of patients is better than the patients who will not present with pneumoperitoneum, because the time or the duration between the onset of the disease and the occurrence of the necrosis in the intestine and the cascades of events that occurs will be more longer in patients who have no pneumoperitoneum. Sometimes the pneumoperitoneum is a blessing for these children because it will direct us to go and do surgery for these patients, and maybe we'll have a good results. The bad news is that patients who need surgery, we have a mortality rate of about 50%. Still, the outcome is not good. And by the way, it is very distressing that if you read about 50 years of activities and 50 years of research in the necrotizing enterocolitis with a lot of information, a lot of good things, but still the outcome did not change. So it's not an easy problem. It's a very dreadful pathology, and it needs a different way of thinking about it. And by the way, here what I want to present you is a sort of a conceptual framework of the surgeon towards a case of necrotizing enterocolitis if he is faced with. This X-rays, or this slide, shows what is the Duke Abdominal Assessment Scale. One of the most important ways to assess and see the progress for cases of necrotizing enterocolitis is doing plain X-rays to the abdomen. And the lack of standardization and the protocol of taking this, because if I ask any of my colleagues, the neonatologists here in the hall, they will tell me a different protocol about at what time we have to take the X-rays, how we take the X-rays, the frequency of X-rays taking. All this is not standardized, and a trial for doing standardization of this is using what's called the DAS, or the Duke Abdominal Assessment Scale, which is a scale from 1 to 10, where we start with just abdominal distensions and increase in the abdominal blood gases until we reach the situations where we have a pneumoperitoneum, or we have here the development of ascites and decrease in the distributions of the abdominal gases in the plain X-rays. But in fact, this type of scale, although it seems that it can lend some objectivity for the assessment of these patients, but in fact, this scale had not been validated on a large scale. So it needs to be validated on a large scales, because it depends on a human factor. So it is objective, but it depends on a human factors that is the surgeon or the pediatricians who are looking for the X-rays and giving them numbers and scores and try to give final scores to determine the time points that we are in need for intervention. And here comes the value, as I heard as well in the many of the presentation today, about the machine learning and artificial intelligence. But I have to tell you something about this, because I am interested in these subjects. Machines needs a large data set to be learned. The human is not. So if you want to have prediction models that depend on the machine learning computerization or computer concepts, you have to have a very large data set of real life data from patients, from the NICU, that can help to build up these prediction models, and accordingly we can introduce the data of the patients, and it will give us in returns an answer for when we have to interfere in these patients based on how does the machine have been learned from the data that we give to these patients, to the computers. And this in fact calls for very important effort that we have to do. Without collaborations and multicentric collections of data in a sort of a network, not only in the necrotizing enterocolitis, but in a lot of pathologies that we are facing as surgeons or as a pediatrician or neonatologist, we will not be able to have a way to reach this prediction model or reach these results or outcome. So I think that we have to call for the development of a network that we can compile, we can group all the data from different centers in one network that can, at the end of the day, help us to reach answers for questions that we need to answer. In fact, in a trial for improving the diagnosis of necrotizing enterocolitis and differentiating between, it's very important concept actually, is to differentiate between the medical necrotizing enterocolitis and the surgical necrotizing enterocolitis. One of these is biomarkers. In fact, we have two big groups of biomarkers, general biomarkers. One of these is the MED7, which is representative of what's called metabolic derangement. And as you see, it is about the acidosis, the sodium, the platelets, the blood pressure. All these factors in the context of patients who are not showing a clear indication for surgery, the deterioration and the derangements of these factors may represent an indication that surgery is needed. What I mean, if we have a patient with necrotizing enterocolitis which is not improving and it's showing a deterioration in these metabolic factors without the presence of pneumoperitoneum, but without improvements in or without progression toward the cure by the medical treatment, this by itself, the trajectory of these derangements of these metabolic factors and the lack of response to the medical treatments may represent a clear evidence or a clear indications for surgery in the proper time, because as I said to you, the most important thing if we want to improve the results and outcomes for these patients by surgery is doing it in the proper time and by resecting all the necrotic tissues that is present, because this represents the monster that perpetuates the problem and perpetuates the pathology and leads to the dismal outcomes in these conditions. Imaging as well is one of the most important modalities that can help us to identify early the needs for surgery. In the new horizon, in the new horizons for the imaging technologies and modalities that we can use is ultrasound. Ultrasound now becomes one of the important modalities that we can use for identifying and for assessment the severity and the need for surgery in the neonates who are a victim of NEC. The different signs that we can see, increase in the edema of the intestinal wall, the presence of pneumatosis intestinalis, and this is the lack of vascularity inside the wall of the gut, which means that we have intestinal necrosis. All these signs can help us to improve our ability to detect the more severe forms of necrotizing enterocolitis who may be needing surgery. But the bad news here is that ultrasound can only say that there is no necrotizing enterocolitis, but cannot say that there is necrotizing enterocolitis. And this is a difference between specificity and sensitivity. I mean that still it is not the solutions for what we are looking for. I know that after my talk there will be a talk about the hazards of radiation in cases of in children and use of CT scans. In fact, CT scan is one of the very important and very sensitive methods to detect the presence of intestinal necrosis, but this occurs in adults. In adult surgery and adult practice, doing CT scan for patients with query intestinal necrosis or intestinal ischemia is very important modality and very sensitive one. And now there is a direction towards use of CT scans in these situations to help improve the ability of the surgeons and pediatricians to identify the presence of intestinal necrosis. This is the hallmark of necrotizing enterocolitis. Is there intestinal necrosis or not? Another important modality to help as well to identify cases who are in need for surgery is what's called NERS, or the near infrared spectroscopy. In a very simple way, when we are measuring saturations of oxygen saturations, we use the sensors and see the global saturation of the child or of the person or the human beings. In the case of the near infrared red spectroscopy, it's a sort of focal assessments of the saturations that occur in different parts of the body. And in the situations of the necrotizing enterocolitis, there is a comparison between the saturations that occur in the splanchnic blood vessels and that occurs in the brain. And if we have a mismatch between the splanchnic circulation and the circulation in the brain, this may represent a point where we have to interfere in these patients. Actually, I will stop on this table because it represents my message for today. Actually, the necrotizing enterocolitis is not a homogeneous disease. It's a very heterogeneous disease, but as anything in medicines, it also had a different phenotypes. Actually, here we have here 1, 2, 3, 4, 5 phenotypes or scenarios that we are facing. The first one is what's called the textbook necrotizing enterocolitis, which obeys and goes with the Wells criteria that all of us know. And this will represent the patients who will develop pneumoperitoneum, and it's easy to say that's okay, we are going to do surgery for them. The second and the most difficult and very difficult one is that the NEC, who does not respond to medical treatment in the form of a persistent of pneumatosis intestinalis, there is no deteriorations, but the patient is still having the disease. It's not progressing to cure. In this group of patients, the indication for surgery may be helped by the biomarkers that I told you about, which is the MED7, the metabolic derangement factors that I talked to you about. Then the NEC with portal venous gas. If we have at any time an X-ray of a necrotizing enterocolitis patients who had a portal venous gas, this equals pneumoperitoneum. And this equals an indication for surgery. An important type, I'm sure that all of us are facing, is what's called the staccato NEC. Staccato NEC is a type of necrotizing enterocolitis which occurs in a very progressive and very rapid manner. The patients will not go through the classic the grades and the classic steps of Bell's classification. The patients will deteriorate very rapidly, and the patients will go into multi-organ failure very rapidly. If we have such patients with staccato NEC, still it is an indication for surgery. The last one is necrotizing enterocolitis totalis. What I want to say about this, nowadays with the improvements in the treatment of short bowel syndromes, with the improvement of the total parenteral nutrition, and with the presence of, at least theoretically for us in our country, the intestinal transplantations, a nihilistic approach towards patients with necrotizing enterocolitis totalis is no more justified. I mean, if even we have necrotizing enterocolitis totalis, still resection is needed, still resection is indicated, and by the using of all these options that I mentioned, we can save the life of many of these patients, and we can have a good outcome for these cases. Sorry? Because of the time, I will stop here, and the rest is something about what we are doing in surgery. I just need to say some few points about the surgery. Actually, we do resection for the necrotic tissues, and then we either do stoma or do primary anastomosis. But we have to be liberal with the use of silo, because one of the problems that can lead to bad outcomes, even if we do surgery for these patients, is abdominal compartment syndrome. So liberal use of silo is important. The damage control surgery principles should be applied. And in these situations, we do the least, because as I told you, we should have a very short time for surgery and not to expose these patients to a lot of physiological stress. And then there is a room for what's called second look operation. So if a surgeon said, okay, we are going to do many laparotomy for these patients, do damage control surgery, and then we are going to do second look operation after 4 to 8 hours, so it is not a big problem. The last thing is, even if we have stoma, how many of you from my colleagues using a refeeding of the effluents that is coming from the stoma to the mucus fistula that we are creating as surgeons? Are we doing refeeding of what we have from the proximal stoma to the distal mucus fistula in our patients or not? We have to adopt this. This can help a lot to make stomas. You will be liberal in doing stomas. Stomas is more safe than doing primary anastomosis. And so if we adopt this policy or strategy, so we will be able to do more stomas, have a lesser complications, and adopt a policy of very early closure. 2-3 weeks we have to go and close these stomas without any hesitation. The last thing that I think is a message that I would convey to you, actually doing surgery in the ordinary operating theaters for these fragile creatures is not good. So why I'm now 35 years try to convince our neonatologists that we should have an operating area in the NICU. We should not take the patients to the operating theaters to do the surgery for him, to avoid a lot of problems you know better than me. So why we don't want to have this? Please, we need to have an operating area in the NICU. Thank you very much, and I hope I was not boring, and I hope I conveyed the messages that I want. Thank you very much.
شكرا